Yes, we do.
Okay. So, so good afternoon. It's never too much to tell. I'm happy to participate to this kind of activity. This subject of my particular interest, it brings talks of different disciplines such as neurosurgery, neuroanatomy, rehabilitation. It's a topic that is always in the frontier of knowledge. Many of the concepts here are still under construction. They change every day. I will comment on the main ones, starting with a few historic elements. I know you had a detailed class on this by Ramesh. I would like to be there for his lecture. And what are the different manifestations of neuroplasticity in our specialty, followed by some examples, and the importance for the present and future neuroanatomy and neurosurgery. So it's difficult to talk about functional neuroanatomy without history. In the early 19th century, we were in the age of phrenology. In Germany, Franz Gall studied the shape of skull as a translation of cerebral areas, looking for associations between form and function. We had the first detailed description of Thornton syndrome when Phineas Gage was hurt in an explosion and this metal bore crossed both frontal lobes. In 1861, Paul Broca from the Kremlin Bicêtre Hospital claimed to have discovered the area of speech by examining the brain of a patient who had lost the ability of speech. And then in 20th century, early 20th century, Wilder Penfield from Canada used cortical electrostimulation to identify functional areas during epilepsy, trauma, and tumor surgery. The first maps were published in 1937, and they are still used today. We saw a sequence of facts that caused the physiological conception of the brain to evolve, to think about the brain in locations, in a localization model. So the brain is formed by a set of specialized areas. So this is a model distribution of mental functions, which is now called localizationism, which has several virtues. We have all learned it in medical school. With this model, we think about topographic diagnosis, depending on signs and symptoms. On the opposite, it allows to hypothesize based on imaging what clinical manifestation would be secondary to parenchymal damage or resection. This same model, which has been so useful, has a number of problems. The first one of this is its rigidity for not taking into account the fact that cortical areas, especially those that are not related to primary executive functions such as motricity in the motor cortex, vision in the visual cortex, they can, other functions, more complex ones, they can change during life. The second is the fact that it underestimates the heterogeneity and the dynamics of the participation of cortical organs. In humans, a task is rarely the result of the activity of one isolated cortical area. It's the product of the interaction of different zones, and participation of each zone in the task is dynamic. It varies depending on the context and how we plan the action. So let's just imagine a football player, for example, kicking a ball. The final action, the kick, is the result of a complex and bilateral dialogue involving not only the motor area, but also premotor, prefrontal cortex, basal ganglia, spinal cord, etc. So the degree of participation of each one of these elements and what each element will do depend on multiple factors, such as time, light conditions, previous training, fatigue, how regular the ground is, the position of the center of gravity of the player. So each action is unique. Now the corollary of this observation is the fact that pure localization model underestimates what has been called odology, that is connectivity. Gall suggested more than 1 century ago, however specialized a cortical area may be, it's useless if it cannot communicate with the other areas. So such a model also underestimates what we can could call cortical redundancy. It's important to specify what I'm calling redundancy here. For many areas, especially those that are not primary executive ones, the function they are able to perform is not their absolute exclusivity, which opens a great door for rehabilitation of some deficits if the appropriate stimuli are provided. So flexibility, dynamism, connectivity, redundancy, those are pillars of brain plasticity in humans. So you have probably already understood what neuroplasticity is. So this is an incredible ability of the brain of changing all the time during the whole life. So indeed, if we think about this organ is made to change. Why? Because it changes continuously. From the moment we are born, even before you are born, to the last moment of life, going through different stages related to age, learning, environment, exposures. And what we become and we are able to do is partially the result of these exposures. Consider not only the environment, but also how we expose our brain to new tasks, repetition and exercise. Of course, respecting the individuality of each one, our brain is a built organ, but it needs stimulation and time. So it's true that different periods exist in our lives, which the responses are not the same. Very roughly, we know that child brain is a critical period for learning. The adult brain also learns, of course, but is marked by the development of self-improvement capabilities, adaptation. So a fundamental characteristic here is what we can call meta-language or meta-processes. There is the higher capacity of cell modulation by understanding processes, modifying them. So manifestation of neuroplasticity occurs in different ways. Short-term, rapid change, such as seen even by Penfield, of modification of intraoperative cortical maps. Medium-term changes induced by slowly evolving pathologies, maybe the case of a slow-growing tumor, for instance. Changes induced by more established lesions, but that will progressively happen in the context of rehabilitation, of course, if you have, once again, the presence of adequate stimulus. So it's clear that recognizing the plastic potential of a given task by a patient will certainly be useful in the near future for surgical planning. So this information may modify a chosen technique, for example, our level of regression, the limits of resection, and the extent of a parenchymal resection. It can dictate the eligibility for rehabilitation techniques and the prognosis of those techniques, for example. So plasticity influences the oncological prognosis, especially for lesions in which the survival is greater or equal than several months. So the potential for compensation, recovery, influences the patient's quality of life. So neuroplasticity is fundamental for the neurosurgery. And neuroplasticity is also fundamental for correct modeling of neurophysiology, of correct cognitive circuits, of neuroanatomy. So contrary to what we may think, and very different from other areas of the general anatomy, there is still a lot to understand about functional neuroanatomy here. It's a rapidly evolving field, and we are still living its history. So in short-term plasticity, the phenomenon can be induced immediately or within minutes after a lesion or surgical regression. The most illustrative examples published are those related to the excision of intraparenchymal tumors in awake condition. In the cortical mappings studied by Penfield in the middle of the 20th century, cases, as I mentioned, of modification of cortical maps after excision of a partial lobectomy were reported. It means that the position of the text should be had to be modified in relation to the beginning of the procedure. So the phenomenon is more common with areas related to language and higher function. It's less common, but has also been reported in relation to more specialized areas such as primary executive cortex, such as sensory cortex. Some recent examples, and language mapping is not uncommon for areas of the temporal lobe that are anterior to the vernix area to respond to electrical stimulation. They may even be near the pole, planum, polare, other areas, superior or middle temporal gyros. These areas, of course, they were interconnected to the rest of the system by important elements of the white matter. I don't have the time to detail them, such as middle sternofasciculus, inferior sternofasciculus, incinate, hundreds of short intergyral association fibers. We know that if the morphological and functional limits are respected, we can perform a temporal lobectomy without permanent postoperative language deficit. So it's true even in individuals for in which those areas, anterior areas, and the topography of ILF and all that responded to stimulation. So in any case, those responsible areas, they are being sectioned and removed during temporal lobectomy. Functional imaging, not always performed, but it helps us to understand how some of these alterations occur. So as positron emission tomography, for example, we see here these color scales. There are levels of uptake of a marked glucose. Captation is greater when the color is hot. This PET imaging crosses what is called crosses cerebellar diasthesis, is a decrease of uptake in the cerebellar hemisphere after a cortical stroke. So in the medial term group, probably would be most important for us. It may take days to weeks to manifest. A very illustrative example is that of resection or injury of the supplementary motor area. The supplementary motor area is located anterior to the upper portion of the motor cortex. Most of this is in the medial aspect of the cerebral hemisphere. It's not functionally defined. It's not a morphological definition. In other words, there is no sulcus or cortical landmark on the brain surface that tell me this is the supplementary motor area. We know, however, that if you draw imaginary, there is a convention with draw imaginary vertical lines from the anterior and posterior hemisphere, we can roughly locate the SMA in position. So SMA is known for participation in planning of complex movements, acting even during the movement, but it's an important center for initiation of movement, including speech, articulation. So it's connected to the rest of the frontal lobe, of course, and the primary motor cortex through those local regional fibers like short U association fibers. And there is recently described Aslan frontal tract that connect or would connect this area to the frontal operculum. So it is so functionally very closely related to the adjacent motor cortex. But in case of lesion of removal, a supplementary motor area syndrome often results, typically manifested by akinetic mutism. The absence of movement, which is contralateral to the injury, of course, would suggest a permanent hemiplegia, but the SMA syndrome is reversible within 12 weeks in the majority of cases. So typically when the patient begins to recover, it's very impressive in large steps. And there is a curious characteristics, which is the motor response to the stimulus would be verbal stimulus during examination. If it's intense enough, the patient will move. So a responsiveness to stimulus, to a vigorous examination, shows that the problem is probably not related to a defect in the common final motor pathway, but is a problem on movement initiation. So it happens that if the patient is able to perform a requested task once during examination, he probably will be able to perform it again. So it opens, once again, a large door for rehabilitation possibilities. So typically, this is the kind of patient that changes dramatically between two visits. So what functional MRI is showing here is using this study of this bold effect, there is the determination of deoxyhemoglobin levels, which are function of the cortical activation, is that before surgery or in the health patients, there is activation, of course, in the primary motor cortex during a task, and the supplementary motor cortex, which is adjacent to the supramumary motor cortex, that's contralateral to the hand that performs the movement. But after surgery, there can be no activation of the supramental motor area because it doesn't exist anymore. And the patient then develops SMA syndrome. A few weeks later, the patient recovers, and what we see now is activation of SMA on the other side. It's now the other SMA that dialogues with the active primary motor cortex, certainly through commissural connections through the corpus callosum. This is a very known example. It can happen not only with surgical lesions, but also trauma and infarction. The progressive character of the lesion seems to be of great importance for plasticity phenomena, giving the brain time for functional reorganization. In a low-grade glioma, such as diffuse astrocytoma, this time may exist. When the lesion is so-called dominant, in the so-called dominant hemisphere for language, areas of language may be infiltrated, of course, such as the Broca's area, and you can have or not have, in a selected group of patients, language disturbance visits in the beginning. So what was described in a very small number of series and case reports is that the individual anatomy can be different from the general anatomy, allowing the subject to maintain a correct speech, even in the absence or great reduction of the participation of this zone for the test. So you see here, even a very eloquent zone such as Broca area can be, with time, no longer indispensable for the function. So the phenomenon can be observed with other types of slow-growing lesions. So unfortunately, I have only this picture, but this cavity was due to a large sphenoid wind meningioma, which was resected. After re-expansion of the parenchyma, you see that part of the hemisphere was definitively lost, including Broca's area. So patient, which was right-handed, was not aphasic before and did not become aphasic after surgery. So there was much less phenomena, this is much less common phenomenon than the SMA syndrome, of course, but its identification is important. So we can adapt the degree of aggressiveness of our therapy and, of course, optimize prognosis. So it would be regrettable, of course, not to recognize this potential in the future. As we see, it depends on some factors, such as the speed of installation, but also the type of function. Recovery after a lesion to primary executive areas, such as motor, sensitive, and visual, are more difficult. And the composition of the injured area in terms of cortex or white matter elements is also important. Touch cortical area may employ all those short and long association pathways to recruit cortical centers involved in a particular function. But if those bundles are lost, the potential for inducing compensation over time is less because there is disconnection. So it agrees with the general idea that we see in the literature that neuroplasticity phenomena are stronger in pure cortical lesions, involving mostly language and superior functions, but is weaker in lesions that predominate in white matter and primary executive zones. So I have an illustrative example, but I will skip it because of time. Just to skip the case, it's and go to what is really important. I'm not going to detail long-term neuroplasticity because it's there is a lot to be with rehabilitation. There is a lot out of our specialty, but there was one aspect that should be stressed is that with training and time, we can learn to recognize and send signals that may be used for more invasive and how can I say modern rehabilitation protocols is an open door for future research, which is human-machine interfaces. So all the times of compensation that we discussed, we see that with the little we know, neuroplasticity phenomena leads us to a more accurate way of conceiving distribution of mental functions. Compensation processes necessarily go through connectivist mechanisms. Without connections, it would be impossible to even imagine neuroplasticity phenomena. So just to finish, there are some illustrative examples. This is just a lab dissection to help us realize the strength of this subject. We see here the so-called short-wave association fibers, how an infinity of those fibers are covering the depth of each sulcus, allowing neighboring functional areas to dialogue with each other. This interaction also occurs with geographically distant areas through many fascicles. I cannot describe all of them now. So this is a summary. Recognizing neuroplasticity means rethinking the localization model and the distribution of mental functions. It be considered in 3 groups, depending on the time of installation: short-term, middle-term, and long-term. All of them are visible in the neurosurgery practice. It presents patterns of evolution and prognosis that differ depending on the task in question, depends on the subcortical involvement. It's said that better functional prognosis are observed when there is preservation of primary executive areas and there is no major disconnection. And also neuroplasticity influences the functional prognosis. It has direct implications for the development of access to this cerebral parenchyma, and therefore it should be studied in depth. So it modifies the personalization of our therapeutic aggressiveness. It modifies concepts in rehabilitation. So I really think that this concept, which looks some years ago very strange in some isolated papers, will be part of a neuroanatomy in the future and should not be only papers, but also taught in medical school and in general anatomy. So this is not one of my pictures, but I like this a lot. Thank you very much.
Igor, thank you very much. That was great.
Thank you, Igor. Thank you, Vladimir.
Yeah. Questions, remarks for Professor Maldonado? It's probably so new and difficult for us that not even trainees who are smarter than we are asking anything.
Actually, this lecture it was supposed to be just after Ramesh, because this is really a continuity of the history. It's ongoing history.